Hello everyone, and welcome to this presentation on how to interpret a chest X-ray. My name is Brijmohan Pandya, and I'm a Clinical Education Fellow at Imperial College London. I would like to thank RadCast for giving me this opportunity to provide this teaching for you. A very quick note before we start the lecture about the images presented in this presentation. They are not my own, and they have been referenced at the end for further reading. Without further ado, let's get started on the presentation. So some intended learning outcomes for this presentation include: you should be able to, by the end of this session, recognize the appearance of a normal chest X-ray, be aware of the pertinent anatomy in a chest X-ray, interpret a chest X-ray using the Dr. ABCDE method, and recognize common abnormalities using this approach through the use of examples and through self-directed learning. So it's important to detail what is not going to be covered. So detailed anatomical structures and all the variants found on a chest X-ray will not be covered. An in-depth detail of all the pathology that can arise in a chest X-ray will not be covered in this presentation. We know that there are other systematic approaches to assessing a chest X-ray. However, we will be referencing the Dr. ABCDE method for this presentation. We will not be discussing or showing you how to assess the positions of tubes and lines on a chest X-ray, as this is beyond the scope of this presentation, and lateral chest X-rays. All the images presented in this presentation will be through the use of frontal chest radiographs. So for our first image, this is a normal chest X-ray, and we will be referring to this during the presentation to reinforce to you what a normal chest X-ray looks like. It is very important that you understand what a normal chest X-ray looks like before assessing and understanding what abnormal looks like on a chest X-ray. There are many structures that can be assessed on a chest X-ray, and in the next few slides, we're going to be looking at some of the main cardiorespiratory anatomy that can be evaluated. So here we can see some labeled anatomical structures that can be assessed on a chest X-ray. As we can see, there are many structures that can be evaluated on the standard chest radiograph. For example, we can see that there are different lobes of the lungs, the heart borders, the great vessels, and the diaphragms. There are also a lot of structures that are not labeled on here that can also be appreciated. For example, the ribs, certain bones, soft tissue, and the spine. This really does show the power of the chest X-ray in not only assessing lung pathology, but overall chest pathology and of the surrounding structures. On this diagram, here we have a colored representation of the heart and major vessels that can be assessed in the chest X-ray. Again, this shows the utility of the chest X-ray in evaluating these major vessels and the heart, and can really help us determine certain pathologies and lead us to investigate further if we see any abnormal pathology. For example, if we see abnormalities with the aorta, we may want to investigate this further with special scans of the aorta to further visualize it in detail. There are many approaches to assessing the chest X-ray, and you may already use a system that works for you. Here, we are going to present the Dr. ABCDE method for assessing a chest X-ray, which you may have come across as a student or a junior doctor. You may be familiar with the ABCDE method. However, adding doctor at the beginning provides a more complete way of assessing the chest X-ray. So what does it stand for? So D stands for details. R stands for ripe, which stands for rotation, inspiration, picture, and exposure. The A stands for airway and the mediastinum. B stands for breathing. C, circulation. The D stands for diaphragm, and E stands for extra or everything else. We will take you through this system in the following slides and go through the various points to assess in each part of the system, and at each point we will reference a normal slide and then show you an abnormal example. Again, to emphasize, this is one system that can be used to assess a chest X-ray. If you are using a system that can equally assess the chest X-ray to this level and you find it works for you, then we encourage the use of that system as well. So let's start off with the details. So prior to assessing any chest X-ray, you must ensure you have the right patient's X-ray. So the correct name. Is it the correct date of birth or age of the patient and their gender? Look at what type of film it is. Is it a PA film? Is it an AP film? Is it direct or supine? You must ensure that the correct marker has been placed, i.e. the left-hand side of the film has an L marker and vice versa. And finally, you must ensure that it is the correct date and time of the chest X-ray you want to look at. As often, there may be multiple chest X-rays taken during the course of a patient's admission to hospital. So let's move on to R, which stands for ripe. So first is rotation. Are the medial ends of the clavicles equidistant from each other with the spinous processes at the midpoint? Then you would look at the inspiration. So can you count 5 to 7 anterior ribs in the midclavicular line? Look at the picture. Is it straight? Can you see the entire lung fields? Are there any angulations present? And are the scapulae outside the lung fields? And finally, the exposure or penetration of the picture, i.e., are the vertebrae visible behind the heart? So let's use a normal chest X-ray to illustrate how we would go through the details in the ripe. So details, we would make sure we've got the correct name, date of birth, age, and gender of the patient. We would make a reference as to what type of film it is. We would then make sure that the correct marker is on the correct side of the patient. So here in this case, we could see that the L marker in the top right-hand corner is on the left side of the patient, and that we've got the correct date and time of the chest X-ray we want to look at. So we will assume that all of that is correct for this chest X-ray. The next section is ripe. So firstly, we would assess for rotation. You can see here that the medial ends of the clavicles are equidistant from each other, and the spinous processes of the vertebrae are roughly in the center of this area. So therefore, we can be happy to say that this film is not rotated. The next step is to look for inspiration. We take our midclavicular line and we count downwards. 1, 2, 3, 4, 5. Usually we should see 5 to 7 anterior ribs in this midclavicular line. In this case, we see 5, so we can be happy to say that this patient has an adequately inspired film. The next is the picture. Is it angulated in any way? Is it straight? Well, it's straight in this case. Can you see the entire lung fields? I can see both lung fields clearly. Are the scapula outside of the lung field? So here's one edge of the scapula, and here's the other edge of the scapula, and they're both well away from both lung fields. And finally, the exposure. Can I see the vertebrae through the heart? And I can see the outline of the vertebrae through the heart. So therefore, we can be happy to say we've checked the details, rotation, inspiration, picture, and exposure of this chest radiograph, and that we are happy to continue. So now let's look at an example where this may be abnormal. Here we can see two chest X-rays, one on the left being the original and one on the right showing a pictorial illustration of some of the things we're about to discuss. So firstly, we can see here that the ripe portion of the Dr. ABCDE method is abnormal. Firstly, rotation. The film is rotated to the right. Why? The medial ends of the clavicles are equidistant from each other. However, the spinous processes of the vertebra are not in the middle of this area. We can see a big gap to the right, and therefore this film is rotated to the right. The next is inspiration. Usually we should be able to see 5 to 7 anterior ribs. However, we can see roughly 2 or even 3 anterior ribs in this chest X-ray. Therefore, this is an under-inspired film. Next, picture. We can see here that the film is slightly angulated towards the right-hand side. Finally, exposure. The exposure is adequate because we can see the vertebrae through the heart. On the right side, you can see a pictorial illustration of some of the abnormalities we have just discussed. In this case, this is an example of a right upper lobe collapse. Now, let's assess the airway and mediastinum. When assessing these two components, you must look at the following. Firstly, look at the trachea and comment on its position. Is it central or is it deviated? Look at any paratracheal masses. Check the mediastinal width. Usually, on a PA film, it should be less than 8 centimeters. Look at the positions of the carina, right and left main stem bronchi. Look at the aortic knob and its morphology. Look at the hilum. Make sure that the left hilum is usually higher than the right. And finally, check the vessels and any signs of calcification. Now that you know how to assess the airway and mediastinum, let's use the example of our normal chest X-ray here to look through some of the components. Firstly, assessing the trachea and commenting on its position. Is it central or is it deviated? Here, it's nice and central, and we're not worried about any deviations. Here, we can look at the carina and the right and left main stem bronchi. In this region, we can also evaluate for any paratracheal masses, which we do not see here. Here is the aortic knob. Usually, it should be crisp and clear to outline. Sometimes you can see calcifications in this area. However, we do not see any here. You can also check for the mediastinal width using a ruler. It should be less than 8 centimeters on a PA film. Finally, you can check for the hilum to ensure that the left hilum is usually higher than the right. Now let's go through an example where this would be abnormal. Here we can see the trachea is no longer central and is in fact deviated to the right. Some of the mediastinal contents are also shifted towards the right-hand side on this chest X-ray. Why? What is happening? Well, we can see here a clear line going down the left lung field. This is actually a pleural line, indicating the difference between lung tissue and air. This is a tension pneumothorax and is an emergency. Let's move on to breathing. What are we going to assess in breathing? Firstly, we assess the lung fields. We can divide these into 3 zones, the upper, the middle, and the lower zones. And we need to make sure that there are lung markings throughout the zones. We must compare both sides and each zone at a time. Check the apices or the top of the lung fields. Are there any lesions or masses we can see in the lung fields? Are there any infiltrates? Secondly, we're going to be assessing the pleura. We're going to be looking for any abnormalities, because usually they're not visible in our normal film. We're also going to trace borders as we did in the previous example, assessing for a pneumothorax or fluid collection in the pleural space. So now that we've gone through how to assess breathing, let's look at our normal chest X-ray again to look through some of these points. We're going to look up and down the entirety of the lung fields, and at each point, divide them into upper, middle, and lower zones. We're going to compare each zone bilaterally to make sure we evaluate for any infiltrates, lesions, or masses. We're going to check the apices or the tops of the lung fields, making sure that we evaluate for any abnormalities such as a pneumothorax or a mass. Next, we're going to look at the pleura. Usually, they're not visible, as it is here in this chest X-ray. We're going to outline each lung field and trace the pleura, looking for any signs of abnormalities, for example, a pneumothorax or a fluid collection in the pleural space. Now let's go through an example where this would be abnormal. Here we can see a clear abnormality in the right lower zone. This is an opacification, specifically of the right middle lobe, because there is a loss of the right heart border. This is due to the loss of the silhouette sign at the right heart border. But we must also make sure that we do not miss anything else in the lung fields. We also trace each pleura and make sure that they're not visible, as they are here in this case. This patient has a right middle lobe pneumonia. Now let's look at circulation. What are the things we're going to be assessing in circulation? Firstly, the heart size and the position. The heart should not occupy more than 50% of the thoracic width on a PA chest X-ray. This can be measured through the use of the cardiothoracic ratio. Usually, 2/3 of the heart is to the left-hand side, and 1/3 is to the right. Next, we're going to look at the heart borders. Usually, they should be well defined and traceable. The right border is made up of the right atrium, with the left ventricle and atrium making up the left border. A lack of clear borders can indicate lung pathology, as we have seen in a previous example. Now let's have a look again at our normal chest X-ray to further assess circulation. Let's start off with the heart size and position. We can see here that the total cardiac width is no more than 50% of the total thoracic width. Additionally, about 2/3 of the heart is towards the left-hand side, with about 1/3 of the heart on the right. Next, the heart borders. They should be very well traceable and defined, as they are here in this case, and there is no clear lack of borders. We can therefore be confident that this represents a normal circulation in a chest X-ray. Now let's have a look at an example where this would be abnormal. First, let's again assess the heart size and position. We can see here that the total cardiac width is more than 50% of the total thoracic width. Therefore, this represents an enlarged heart or cardiomegaly. We can then therefore trace the heart borders, and we can see that yes, they are very clear and well defined. We also note an abnormal foreign body here. This represents a previous mitral valve repair. Here you may notice some wires. These are sternotomy wires indicating previous chest surgery. So overall, this chest radiograph is in keeping with cardiomegaly in a patient who's had previous mitral valve repair. Let's move on to D, standing for diaphragm. Let's look at the things you're going to be assessing when looking at both hemidiaphragms. First of all, the right hemidiaphragm should be higher than the left. Look and check the shape and contours of each hemidiaphragm. The stomach can be located by assessing for a gastric bubble, which is usually present under the left hemidiaphragm. Check for signs of free gas. If it is present, it indicates a perforated abdominal viscus. This is pneumoperitoneum, and if it is found, this must be escalated and discussed. Finally, look at the costophrenic angles. They should be clearly visible and sharp, well defined. If you have a loss of a costophrenic angle, this is a result of costophrenic blunting and can indicate fluid or consolidation or even lung hyperinflation. Once again, let's refer back to our normal chest X-ray to have a look at the diaphragms in more detail. We can see here the right hemidiaphragm and the left hemidiaphragm. The right is higher than the left. We can see here the presence of a gastric bubble. The costophrenic angles are sharp and well defined here. There is no signs of any free gas under both hemidiaphragms. Therefore, this is a normal appearance of a right and left hemidiaphragm. Now, let us look at an example where this is abnormal. Here we can see both hemidiaphragms, with the right being more higher than the left. We can see a very well sharply defined edge of the diaphragm and a sharp costophrenic angle on the left. Same here on the right, sharp costophrenic angle and a sharp contour of the hemidiaphragm. However, some of you may have spotted that there is free air or gas underneath both hemidiaphragms. This represents a surgical emergency as it is indicative of pneumoperitoneum, a sign that there has been an abdominal viscus that has been perforated. Finally, let's now come to E in the Dr. ABCDE method. E stands for extra or everything else. If you haven't assessed for the mediastinum, it can be assessed now. Check the aortic knuckle and the aortopulmonary window for signs of aneurysm or malignancy. Look at the bones, including the ribs. Check for signs of fractures, dislocations, or any lytic lesions. Look at the soft tissues. Are there any hematomas present? Is there evidence of any surgical emphysema? And finally, assess for any tubes, lines, valves, and pacemakers that may be present. Tubes that are commonly come across in hospital are things such as NG tubes, or an ET tube, an endotracheal tube. Chest drains, for example, that we have seen before, can also be commonly come across. Lines could be things such as a central line, a PICC line, or ECG cables if the chest X-ray is taken in A&E, for example. Certain valves, as we have seen, can also be seen, for example, an aortic valve replacement. And finally, look for signs of a pacemaker, PPM standing for permanent pacemaker with wires. You can also look to see where the leads can go, or an implantable cardio defibrillator. Finally, let's come back to our normal chest X-ray. We can immediately see here that there are no tubes, lines, valves, or pacemakers, or any other foreign bodies. If we haven't assessed for the mediastinum by this point, now is the time. We can look at the aortic knuckle and the aortopulmonary window to check for signs of aneurysm or malignancy. We can look at the bones, for example, the clavicles, the scapulae, the anterior, posterior ribs, and even the spine, for example. We can look at things such as fractures, dislocations, or any signs of any lytic lesions. And finally, we would then assess for the soft tissue to look for signs of any hematoma or any evidence of surgical emphysema. So here are our final 3 examples where this may be abnormal. If we look and start with the leftmost chest X-ray, we can see here a line coming down in the midline, going below the left hemidiaphragm. This would be indicative of a NG tube, and it is in the correct position. If we come to the middle chest X-ray, this shows a chest drain inserted due to a left-sided pneumothorax. However, the chest drain is actually malpositioned, as we can see here, as there is a hole outside of the rib cage. Finally, if we come to the rightmost chest X-ray, we see a permanent pacemaker, a dual lead permanent pacemaker with 2 leads, one going into the atrium and one going into the ventricle. This shows you some of the lines that may be assessed in a chest X-ray. To conclude, what has been covered in this presentation? We've seen what a normal chest X-ray looks like and given you examples where abnormalities can arise, including their appearances. We've looked through and referenced and discussed an example of using a systematic approach to assessing a chest X-ray, in this case, the Dr. ABCDE method. Here are the references I have used for this presentation. Here I have referenced the images that were used in the presentation for you to look at if you wish to. Thank you very much for listening to this talk, and I hope you now have a better understanding of how to use the Dr. ABCDE method to assess a chest X-ray. This should hopefully serve you well in your student rotations or even postgraduate jobs. Thank you very much and goodbye.